right, Sek, when Filipinos hear about healthcare system, they automatically think long queues, overcrowded hospitals, very expensive.
That's probably number
diba?
one.
So how would you describe the current state of the Philippines healthcare system?
Well, I've been a doctor for many years, and true enough, many patients will come pagka na sila, when they cannot work, they cannot go to earn money.
Yeah.
That's the time they will go to the hospital or to the doctor. So that's a little bit too late. So we're trying to change that kind of behavior. When we passed the Universal Healthcare Law for the Philippines, where that means access, equitable for healthcare, accessible, equitable, and affordable. Those are the three elements of Universal Healthcare Law. So yung access, nagtayo ako ng BukAs centers. These are the bagong urgent care and ambulatory services center. I now have 61 operating all over the country. I only targeted to build 28. Now I have 61 all over the nation. I just inaugurated the most recent one in Tolosa, Leyte, number 61.
Okay.
And it's a polyclinic or urgent care that's available in the community.
Right.
It's like a hospital without the bed. So everything you needed in a hospital. Alam mo kasi, Angela, 80% of the people that go to these very big, busy hospitals just want outpatient diagnostics, a consultation, and then a prescription and medicines, and then they'll go home. Nobody wants to be admitted. The problem is 80% go to the big DOH hospitals that have been developed over the years. Kasi nagkaroon ng syntax, nagka-funding, na-develop yung 83 DOH modern facilities. But it also caused an overcrowding because yung mga tao, binaypass na nila yung local government hospitals, yung barangay health stations, because anyway, the equipment and the diagnostics are enormous.
Right.
So ngayon, binadala ko naman yung community sa
Well, that's a good initiative, no? Because a patient's journey doesn't end, diba, in the hospital alone. Kailangan nila ng mga laboratories and medicines are greatly important
and imaging,
as well.
yung x-ray, ultrasound, CT scan, yan ang mga kailangan ng pasyente. And with the modern day of how we practice medicine, iba na nung araw.
Right.
Stethoscope, prescription, paper, okay na ang doctor. Today, i-x-ray ka, ultrasound ka, CT scan ka pa. So, medyo nag-iba yung the way we treat patients. But we also now do a lot of outpatient operations. We also do a lot of procedures. So if we can do them na parang fast food, like what happened with the BukAs is, it's open from 6 a.m. to 10 p.m. I use 2 shifts of personnel. And there's urgent care. So if you have an emergency, you don't have to go to a big emergency department na pipila ka for long hours. And then matagal bago ka tingnan.
Panis ka nakakaantay.
Uunahin kasi nila yung namamatay.
Yes,
It's
yes,
called the
yes.
triage system. So
right.
if you're that dying, they make you wait for
That's
hours.
true.
Yeah, so that's
Which
what
makes
happens.
sense naman, di ba?
So we want to decongest that, and you bring you to a place na run by the family and community medicine people. So in 1 to 2 hours, na process ka nila, and it's successful.
So how many BukAs centers do we have right now?
61 now.
61. The target was 28
Yeah, I
when
said,
you initially
when I launched it in
planned it.
2025, I said 28 BukAs centers for the 28 million poorest Filipinos by 2028. It was so successful. By the end of 2025, I already have 60. So talagang blockbuster siya.
Yeah.
So what happened there is the facility, the first facility ko kwento ko lang sa'yo, was a TTMF, yung temporary treatment and monitoring facility. It was a small hospital in a town in Pampanga. And Santo Tomas, Pampanga, and they used it during COVID. After COVID, the mayor donated it to the DOH. I don't have the money and the salary to run that as a hospital. So we accepted it, and I told my medical director, remove the beds and bring in diagnostic equipment, x-ray, and then we create clinics. So may clinic for hypertension, may clinic for diabetes, may clinic for the buntis. And it was such a hit. So,
Right.
And then this was run by the medical center chief, who knew how to really run the hospital. So it was copied by the other medical center chiefs. So each of my hospitals started building BukAs centers or repurposing old clinics that were
So
built.
60 plus BukAs
61
centers.
now.
61 now. Madami siya, but compared to the millions of Filipinos who need, diba, these kinds of services. So how does DOH identify which areas dapat unahin, 'di ba? Saan dapat mag-build nitong mga centers na ito?
So we've shifted when we passed the syntax law in 2020. 2012, 2013, we were able to modernize the DOH hospital. So actually, the DOH hospitals have very good equipment. CT scan, MRI, ultrasound, nice operating rooms, may robotic surgery, may linear accelerator for cancer. But the problem is all the patients started going to them, na crowd. So ang thrust ng universal healthcare, UHC law, is access. And access can be done through better primary care. So primary care is the first contact of a patient. Importante yun na may mapupuntahan sila when they feel bad. So they don't go to the hospital immediately. You should go to a facility. Actually, meron na tayo niyan dati, yung mga barangay health station. But today, the illnesses are more complex. You need CT scan, X-ray. So we had to build that polyclinic model where patients can go. So itong model na to, very useful to the working class kasi they can go there early in the morning, have their child checked up, get a prescription, go home, and still go to work at 9 o'clock.
Right.
And then when they go home at night, since it's open until 10 p.m., may sakit yung asawa niya, they can still go there and consult until 10 p.m.
Pero ito po, may bayad yung mga services. Free din to.
So it's also, all the services
DOH.
are government. So the diagnostic tests are free. It's all covered by PhilHealth. So
are we also planning to expand it sa mga far-flung areas, which is mas kailangan ng mga tao dun because ang hirap yung accessibility sa kanila.
So I took another loan. So I took a loan from the World Bank. It's $400 million. And it's for a 4-year project to build 250 health facilities, health centers that are modern with solar power, Starlink or internet connection, and all the diagnostics that are available point of care. And this we identified 17 provinces, GIDA areas. We called it geographically isolated and disadvantaged areas. So the idea to start building those. So that commenced last September. So I'm due to build 250 of this in the next 4 years. So this is like the next step, the BukAs, and then the primary care facility, another health facility for diagnostics. The title of this project was the Health Systems Resiliency Project. You can Google it online. And it's about increasing capacity in the rural areas, in the remote areas. When there is a pandemic, we can test. We can do testing there. We don't have to send the specimen in RITM to know whether
tagal pa
babalik pa. Then you have the logistics pa of how to get the specimen
Right.
With this, everybody becomes more accessible, even in the remote areas. And I'm going to use it for TB. For TB detection and TB selection.
Right. Do you think this, because I remember talking to a healthcare workers a few months ago, they're concerned about zero balance billing. At sabi nila, most hospitals right now ay hindi kayang tugunan yung increase of number of patients because of the zero balance billing. Do you think, kasi there's a mention of lack of space, diba? Lack of equipment, yung sa mga laboratories, yung mga workups, at saka, of course, yung lack of healthcare workers. So do you think this somehow, itong BukAs centers would finally address that concern?
Yes, actually true, no? If you don't need to be admitted, you don't have to be in the hospital. And I told you before, 80% na nagpupunta sa big medical centers do not need to be admitted. In fact, we perform surgery in the BukAs centers, yung day surgery. You get operated on the morning, you go home in the afternoon. So, yung zero balance billing, some hospitals are unable to fulfill it, and these are what we call the local government-run hospitals. So there are many kinds of government hospitals in the Philippines, and this is the confusing part. I have 83 run by the Department of Health. The Department of Health is probably the third highest budget in the national agencies, education, DPWH, and then health. But we decentralized healthcare. We also gave healthcare in 1992 to local chief executives. So may mga governor and city mayor na nagpapatakbo ng sarili nilang hospital. And they get their income from the PhilHealth reimbursement. So these are level 1 hospitals, mostly level 1, some level 2, and a few level 3. Most of the big centers are DOH. We are able to do the zero balance, and that's why when I proposed to the president zero balance only in DOH hospitals, it's because we have retained income. We, as an agency, are allowed to retain income that we got from the year and use it for more services. Therefore, that's what's fueling the zero balance billing in DOH hospitals. The good thing is, in 2026, we now have budget for what's called the Zero Balance Billing Support Fund. So the national government, through the congressmen and senators, put in 1 billion pesos additional, came from the flood control. And then it's put there for services so that I can support some LGU hospitals to fulfill the zero balance billing.
Because I understand not all public hospitals are DOH hospitals.
Correct. Only 83 are...
Exactly. And sa dami ng mga nagkakasakit every day, so ito yung tingin nyo na makakatulong. Pero ano po yung parang alam ko pa yung accredited, mauunang ma-accredit no? Ng local government?
We decided that there are some LGU hospitals na provinces actually that have started to do zero balance billing even before the national government started it. So sila una kong tutulungan kasi they're giving zero balance anywhere. So I'll give some
support. Can you tell me the name?
Well, there's Cotabato, there's Sultan Kudarat, there's Bataan, there's Pampanga. Those are some of the provinces. Batangas. So these are some of the provinces we will help with the fund. But all other hospitals, tinutulungan din naman namin yung patients through another fund called the Medical Assistance for Indigent and Financially Incapacitated patients. MAIFIP. So there's the MAIFIP fund, which is for individual patients asking for additional financial support. And then, of course, PhilHealth, I'm increasing all the benefit packages of PhilHealth. There's an 80% increase in the, what we call the case rate or the benefit when you get admitted. We've also increased heart attack, we've increased the dialysis. So I had my classmate who underwent cataract surgery. Wala siyang binayaran because we increased already, and then you can use the intraocular lens na bifocal pa. And he didn't pay a single centavo. He even called me. Thank you, wala akong binayaran sa ano. So because of this, these are combination of financing methodologies that's going to lighten the burden for our Filipinos. Ang binibuild namin ngayon, and the utos sa akin ng President, is to concentrate on the middle class. The poor, covered na natin eh. That was the old no balance billing. If you remember, the original name was no balance billing. And many people get confused. No balance billing and zero balance billing seem to be the same. No, it's not.
Okay, sige, let's differentiate it. Isa-isahin natin. Ang dami mong sinabi, Secretary, pero lahat yun very interested ako to know more about it because ang daming confusion na online, di ba?
Health system is very complex. And even some of my colleague doctors, hindi naintindihan yung how health is financed.
Okay, so zero balance versus no balance.
Zero balance, ang precursor nito was the no balance billing in 2012. I was undersecretary then. There is the indigents, the really poor people, part of the Pantawid Pamilya program or the Poor Peace, yung binibigyan ayuda. And if they get admitted in a DOH hospital, we develop the no balance billing. So anong problema doon? You have to prove you're indigent. You have to prove you're poor and you have no income. And then the hospital won't bill you na. PhilHealth lang, okay na yan. That's in DOH hospital and many LGU hospitals implemented it. Okay lang.
Basta sponsored member ka.
The problem is if you have work and you have income, sisingilin ka ng hospital.
Exactly.
For medicines, for tests and everything. That's what BBM changed. In his SONA last July, sabi niya, bayad na bill nyo. Basta na-admit kayo sa basic accommodation or ward accommodation in any DOH hospital.
And we're talking about not just yung mga, ito yung mga, tawag dito, kahit may kakayahang magbayad. Basta sa ward ka.
In fact, I visited a patient in NKTI. He is unemployed. He's employed BPO. Hindi maliit ang kita niyan. May HMO siya. In one day, naubos in a private hospital. And he had cancer. So he needed an operation. The operation was like a 400,000 peso cost. He went to the outpatient of NKTI. He was seen there. Na-admit siya. Of course, the basic accommodation is air-conditioned, pero may kurtina.
May kasama.
May kurtina. May kasama ka dun sa floor na yun, pero may kurtina kasi yung privacy.
But once you avail private room, hindi ka nakasama sa zero balance
billing. So yun ang klaro natin. Pag ikaw nag-pay, you're a private patient, you cannot get zero balance billing. You have to be in basic accommodation. So itong taong to, binayaran ng hospital 450,000. Operahan siya. Well, zero. Wala siyang binayaran.
Do you have data sec of how much percentage?
So from July to December, we have 1.3 million patients discharged in all 83 hospitals.
Zero balance billing.
74.6 billion pesos has been spent. In fact, kinumpute ko na yan. Sabi ko, what is our average cost per patient? At that computation, I discovered we're spending about 57,000 pesos per patient. That's the average. But I've seen a patient discharged with 2.7 million as a bill. Zero din binayaran niya. So nagre-range yun. Merong mas maliit, meron covered na lahat. What we've discovered is 30% of what we pay for, of the financing, comes from the PhilHealth. The reimbursement to the hospital, let's say kung 57, so gawin na natin 60,000. So parang mga 20,000 dyan, PhilHealth nagbayad. And then the remaining other 30%, another 20,000, binayaran ng MAIFIP. And then the rest, yung ang tinatawag naming operating expense and personal services, yung sweldo ng doktor ko, nurse, at saka yung gamit namin sa ospital. So that's how we are financing zero balance in the DOH hospital. So,
we have to clear that, in DOH hospital.
Punta kayo sa DOH hospital, including heart center, kidney center, and lung center. So all our hospitals, 90% of the beds are basic accommodation. Only 10% are private or pay. Pag nag-private ka kasi, talagang you now are saying, I'm going to pay. I want a private room, I want to pay a doctor. So never go to a private room and then ask for ayuda as zero balance because you are now excluded. So pupunta ka dapat sa basic accommodation and everything will be free. Sa heart center, ganun din. At kidney center, 70-30 naman doon. Because it's a corporate hospital, they have to earn income to pay for the basic accommodation. So 70% of the beds in heart center are pay beds. And then only 30% are basic accommodation. Yun yung zero balance, 30%. Sa private naman, baliktad. Only 10% are basic accommodation and the 90% is pay. Now, sa pay, hindi pa zero balance kasi because it's funded by the hospital themselves, by private corporations, they'll still charge you, but it's a lower rate. And your PhilHealth may pay 70%. So mayroon ka pa rin out of pocket. So sa hospital, sa DOH, wala ka ng out of pocket. So your out of pocket will be pamasahe, pagkain, etc.
But you mentioned about increasing bed capacity in one of your interviews. Kamusta na po yun? What's the update on that? Kasi yun din po yung nirereklamo nga po ng mga healthcare worker na na-interview ko before na, diba? Okay, hindi natin kaya yung bed capacity.
Bed capacity is a more complex problem. Why? Because when you increase beds of a hospital, you increase nurses, you increase doctors, you increase. So we don't have enough nurses. So I'm not as hot to increase the beds. What I want to do is engage local government hospitals as part of my overflow. So ang mangyayari ngayon, and this instruction is now given to my hospital directors, big medical centers of DOH will engage local government hospitals and pass on our excess capacity patients to them na pwede dun sa level ng hospital nila. And then we will just help pay them to be zero balance. So the zero balance. The other one is I also ask them to tie up with private hospitals. Yung sabi ko kaninang 10% ward beds in the private. And we will also support the parang pay ano tawag dito? Zero balance for the ward accommodation. So we'll try to expand using LGU hospitals and also the pay hospitals and also the state university hospitals. May mga state university. PGH is not a DOH hospital. It belongs to the University of the Philippines. They also do zero balance. West Visayas State University Hospital sa Iloilo. Ganun din yan. May MSU. So these ones are all the government hospitals that are actually doing zero balance.
Okay, because I remember going to PGH and other public hospitals. Well, we also talked about it na hindi naman lahat ng public hospitals ay DOH hospitals.
Correct.
Pero the main concern there also is yung, of course, napakahaba ng pila to be able to get healthcare, benefits. At saka, ultimo, cotton buds, binibili nila pag nasa public.
Pag walang supply, if the management of the hospital is not good and their supply runs out because of the many patients,
Hindi out of pocket din
magiging
yun.
out of pocket. No. So, ngayon, merong mga consignment procedures so that, kasi ang PhilHealth will not pay you pag pinabili mo ang pasyente sa labas. So, actually, na-correct na yan. Dati yan, ganyan. Pero ngayon, PhilHealth will not pay you once the patient says, pinabili ho ako ng ano sa labas, bulak.
Diba?
So, bawal yun. So, in the policy,
cotton buds, tissue.
Nung no balance pa yan. Pero ngayon, bawal sa PhilHealth yan na pabibilin mo yung patient ng other sa labas. usually ginagawa namin consignment. Ang ginagawa nun para hindi ka ma-deny ng payment ng PhilHealth, binibili na lang namin sa labas, binibigay namin sa patient.
Alright, so you mentioned maipip, di ba? Ito
Yes.
yung, of course, yung very controversial na guarantee letter, GL. Di ba, sabi nila, bago pa ito napag-usapan, talagang humihingi yung mga kababayan natin ng guarantee letter from the politicos para makapag-avail nga ng mga healthcare, makakuha ng percentage of the amount para mabawas sa mga bill nila. So ngayon, as we speak, we can say na hindi na po tatanggap ng guarantee letters from politico.
Well, they put it in the provision. The law, the General Appropriations Act actually said there should be no intervention from the elected officials. So, but of course, if you ask me, of course, an elected official ang pinupuntahan ng ating mga kababayan when they're sick. Apparently, I don't understand this, but that's what our poor people go to. They go to the mayor, they go to the congressman. Of course, the congressman will refer to us, the public hospital. So, if a congressman or a senator or a mayor writes to me and says, tulungan mo, of course we will help them and we will use the MyPip. So basically, that big fund placed by the congressmen and senators in our budget will be used to help constituents that they refer. So it's now a referral letter to assist a poor patient. So, Pero the fund, when it was developed to support PhilHealth. Kasi nung araw, napakaliit talaga nung value ng PhilHealth. Ngayon ko lang naman na-i-increase yan as chair of the board of PhilHealth. So we're slowly increasing it. So in the past, naisip nila, why don't we put a chunk of the money instead in the DOH budget to help these patients needing more financial assistance. Tapos na-expand na yan, binabayad na rin sa private hospital, binabayad sa mga lugar, mga lalawigan, provinces where there is no DOH hospital. So the people are forced to go to the private hospital or to the LGU hospital.
So ngayon, wala na pong GL. Meron pa rin.
So the guarantee letter is not ours. The guarantee letter comes from...
Kumbaga po, hindi na po tatanggapin ng mga DOH hospital.
Oo. Kasi the GL system was a previous system. So now, sinasabi namin, may fund available for indigent and financial incapacity. And ito yung gagamitin natin. The Congress will still monitor how we use these funds. And then yun nga, i-divide din natin yan. Gagamitin ko rin yung MyPip as it was to be used for, di ba, 30% of our zero balance comes from MyPip funds. So pag pinapunta mo yung patient mo sa akin, zero balance billing ko yan basta nasa basic accommodation. And kung walang DOH hospital, babayaran na lang namin yung hospital na willing to accept funds from DOH.
Alright. So you also mentioned about middle-income workers. This time around, they're in the discussion. Diba? Nasa table na rin po kaming mga middle-income earners.
Correct.
Na kami po yung mga, or sila po yung mga main contributors sa insurance fund natin.
Yes,
So, what are the programs for them?
People with salaries, like everybody here with salaries, you get a salary deduction for your
every month.
PhilHealth every month. And it's quite big for people. Ang maximum niyan is 5,000 a month. So, 2,500 from the company, 2,500 from you every month. So that's your salary anyway. That's actually 60,000 a year. Kung earning 100,000 up, less than that mas maliit. So so ano yan, graduated na according to law. And they're complaining kasi I contribute and then lalagay mo ko sa basic accommodation. So my idea is to develop an area for the direct member. Ang tawag kasi sa nagko-contribute is direct. Because that didn't come from government. That came from your salary. And you're contributing it as part of solidarity to a health fund.
Right.
And we know when 100 million people contribute to a health fund, we know only 10% will get sick or get hospitalized. So parang paluwagan yan, palitan tayo. When I'm sick, that fund will help me. When you're sick, that fund will help you. When your family gets sick. So it's something like that. It's called solidarity. That's another concept of universal health coverage financing. Wherein, hindi naman dahil nag-contribute ka ng 60,000 din ang makukuha mo that year. You may not get that. It's called a pay-as-you-go insurance, like your car. How much do you pay for the insurance of your car? Pag hindi ka nabangga for that year, wala na yan. That was a contribution to the people who get into a crash. But, if you get into a crash and it costs like 100,000, yung binayad mo, sulit. Kasi, nabayaran ng insurance for that. So that's how health funds work. It's like a pay-as-you-go insurance. It's not like a retirement na itatago natin sa bangko and then hihintayin mo mag-retire and then you give it. It's every year. A certain part of the population will use the funds. Kakailanganin nila yun dahil nagkasakit yung nanay nila or sila, and then babayaran natin yung hospitalization.
Kasi
So yung
maraming nag-react Of course, yung mga middle income workers na finally, 'di ba, mapapansin kami at merong magagawa for us.
Correct.
'Di ba? So ngayon, ano yung specific that you can share with us na pwedeng magamit, 'di ba, ng mga middle income workers na hindi na nila nagagamit before?
So there are two in the pipeline. No? Number one, I'm trying to develop, if you're going to the DOH, I'm going to put you not in basic accommodation, but in a separate wing na medyo mas private, medyo two in a room lang. And then, there's more privacy. So hindi siya masyadong naka-aircon din siya, di ba? So that, at least because it's a direct contribution, you get amenities that are amenable to the fact that you're a direct contributor to PhilHealth. The second one is we're trying to develop a program called PhilHealth Plus. And this is also in the law, that if you pay additional, pwede kong taasan yung premium payment mo. Let's say na open heart surgery ka, pwede natin sagutin mo up to 80% of the cost. So pwede ka na mag-single room with that particular PhilHealth Plus and still be able to have very small out-of-pocket. Ang mabigat kasi sa middle class is what we call the out-of-pocket expenditure for health, for catastrophic illness. So when someone gets cancer, heart attack, or stroke, mawa-wipe up yung income ng family. Di ba? Wala nang kakainin. Wala ka nang pambayad sa rent, wala ka nang pambayad sa pamasahe at sa pagkain ng pamilya mo. We don't want that because we don't want people to be into catastrophic spending just because they got sick. The state will take care of you. PhilHealth will take care of you. So yun yung konsepto ng solidarity and my terms concentration to be able to address the working class, the middle class, the taxpayer. Kasi nga for many years, the government had concentrated on the indigents. Okay na indigents
Sponsored members.
Sponsored member. Covered na natin yan. In fact, yung tax nga na binayad sa kanilang premium, galing din doon sa working class kasi yun yung bumili ng sigarilyo at saka alcohol, di ba? From your income.
Exactly.
Nabayaran mo tuloy yung kanilang premium dahil wala silang pambayad ng premium. So sila una natin na pagbigyan. So that's solidarity. Now, it's time to give better health packages from the government to the middle working class.
Now, Sec, I wanna ask also, yung mga hazard pay ng frontline workers during COVID-19, it's still an issue today.
Wala na, bayad
na lahat.
Okay, so this is what happened. So, may kulang pa nun. I think about 27 billion. Yun yung kinuha ng finance doon sa PhilHealth na excess funds. So, they paid that finally. So, bayad na yan. Meron pang nagsasabi di sila na bayaran. But I'm sorry, there was a deadline to claim. So, if the hospitals were unable to claim, pina-audit na namin yan. So, that's sorry. Kasi, padagdag ng padagdag. The funny thing is, when we started paying, biglang naglalabasan pa isa-isa ang mga taong sabi nila, hindi, nag-serve din kami. Ba't hindi kayo nag-claim before? We moved the deadline 3 times.
So it's a done deal.
Done deal na yan, tapos na yan.
So kahit may humabol, hindi na. Kahit
they
totoo
can still
nagsasabi
claim.
ng totoo.
They'll do a money claim. They'll do a money claim. You do a process, prove to us na
kawawa
talaga.
naman, di ba? It's during COVID-19, these are our heroes.
Pero sila, majority na ba? We paid about 100+ billion to this. So ako, to me, na-claim na yan ng mga ating workers.
Alright. Okay, so we don't have much time, but
yes,
the last question I would like to ask you, what is the single most important change in the healthcare system that Filipinos will feel before your term ends?
I think the single most is lowering the cost of healthcare. I want it to be affordable and of quality and also accessible. So for everything I described, the Health Systems Resiliency Project in the GIDA areas, the BukAs centers, the zero balance billing in the big hospitals, these are all targeted to making healthcare not a problem of the citizen. Di ba? Parang, bakit ba nagkakautang? The number one cause of bankruptcy of a Filipino family is because they get sick. Someone gets sick. I'm hoping that when I finish in 2028, hindi na nangyayari yun. That people will go confidently and be in a hospital and be actually admitted. I have even better ideas na people will now have better health-seeking behavior. They're more literate. They'll take care of themselves with proper diet, exercise, discipline, not taking drugs or alcohol, para their wellness is maintained. Then they don't get sick. So malaking bagay yan. And you can do that through nutrition, exercise. So very important.
I have one last concern pala. Mental health issue.
Yes.
It's a big issue right now also, and karamihan po sa atin na instead na ibayad po sa psychologist yung kanilang pera, bibili na lang nila ng pagkain. So my question here, di ba, paano po yung aspeto na yun? Napakamahal daw po ng mga healthcare professionals pagdating sa...
Of course. But again, it's just like the hospital system. You can wait until you're mentally ill and then you get a psychiatrist. That's expensive.
Right.
But if we talk about mental wellness, if you have life-work balance, if you do sports or arts, or you have social networks that support you, you won't need a psychologist or psychiatrist. Everybody gets anxiety, everybody gets depression, but it's our social network and our family that will prime up. So we've made accessible, also in the BukAs centers, mental health through our family physicians. It doesn't have to be a psychiatrist to do that all the time. What's important is, parang fitness yan eh. If we eat well and we exercise, hindi ka tatamaan ng sakit kasi fit ka. Pero kung puyat ka lagi, depressed ka lagi, di ba? Sigarilyo ka ng sigarilyo lagi, walang mangyayari sa'yo. You'll really get sick. So, very important is the role of the individual citizen also in maintaining their wellness and their mental wellness as well. Not only physical, pati yung mental. And maraming pwedeng gawin to do all of that. Even, tawag nila doon, meditation or awareness.
Pero
and all
kasi
that
syempre, I understand your point second, no? Pero syempre, if we talk about inclusivity, yung mga ibang kababayan natin, wala namang means to have, to get their own
there's
hobbies.
a mental health law,
diba?
merong mental health law, it also pays for consultation. So PhilHealth also pays for consultation with a mental health professional. For up to 1,500 yata yung per consultation na yun na available. So that's in the mental health law. So available yun. I sit as chair of the Mental Health Council and we're creating more programs to address mental health. Our mental health problems are mostly with our youth.
Yes.
So we're addressing them at the school level, at the CHED level, at the college, because dito yung number one is a family problem, number two is romance. Yan ang mga triggers, triggers for mental health, and yan yung mga self-harm, thoughts of self-harm and everything because of depression, iniwan ng boyfriend, or failure in school, di ba? Yung ganon. So we're addressing that through guidance. And sa sa ibang schools, ang ganda, may peer support systems. The senior high supports the
Parang
younger
body
people,
up,
the body system, because they don't listen to the seniors to order them around.
Yeah.
But they'll listen to
There's
their...
a generation gap.
Si ate, di ba? That's correct. That's a general. So pag pinagsabihan ko yung anak ko, tataasan lang ako ng kilay.
Saka hindi natin pwedeng sabihin na nung during our time ganito.
Ako,
You cannot compare. Diba? You cannot compare.
The eyeballs will roll.
Speaking of the youth, mataas po ngayon ang cases ng HIV among the youth. Diba? That's also a problem.
So, I have 60 new cases of HIV nationally every day. 30% are below the age of 18. That's about 20. That's a lot.
Tingin mo saan nanggagaling yan?
To me, these are very young people that now will end up with antiretroviral therapy for the rest of their life. Parang too young to be an HIV positive to me. Before, a decade ago, our HIV positives were 25 to 35 years old. Today, meron 12. We have 12. Majority are 15. The sad part is when a youth like a 15-year-old gets positive, we need parental consent to treat them. We lose them. From the treatment hub, they turn out positive, they disappear. We've had cases that they would come back with advanced HIV. Mahirap na gamutin and will become AIDS. Sayang, di ba? And I think I can understand the demographic, because our demographic of the key population are boys having sex with boys. Diba? If you're a boy and then you got HIV from this kind of gender choice, mahirap sabihin sa tatay mo yun. So they just disappear and we don't find them. So they come back more advanced. So we just hope more testing. We're increasing testing, making it available in the treatment hub. We're getting young people.
And these are free testing, right?
This is free testing. Even the ARV is free. It's covered by PhilHealth. You cannot buy the antiretrovirals from the butika. You have to go to a treatment hub to get this. But it's available basta magpapatest ka. So I'm hoping our youth kasi I think is the generation that didn't see the AIDS. I grew up, I graduated medicine in 1983. That was the year the AIDS virus was discovered. And we saw on magazines and TV shows what an AIDS patient looked like. I handled AIDS patient in
So
the
do you think
hospital.
there's lack of awareness
I
campaign?
think there's a lack of awareness, and that's what we're hyping up. We want more people to understand what is AIDS, how do you get HIV,
Right.
how do you prevent getting HIV. Now there's even PrEP, prophylactic meds for if you had been on risky exposure. There's also the use of condom. Of course, I will not stop use of condom because it also prevents the other sexually transmitted infection. So
Yeah.
kailangan din talaga yon. So condom use, and of course, being honest with your partner. What is your status? So that means getting tested
Right.
regularly, especially if your sexual preferences
But there
are
are other ways to get HIV, like of course yung shared
Blood.
needles,
Well,
blood.
very little in the Philippines. 90% of us is young men having sex with young men. So that's our number one.
That's a study.
Yeah, that's the statistic. That's the demographic. Ang prostitutes kasi, or what they call not prostitutes, the sex workers,
Nocturnal workers.
the sex workers, the nocturnal workers, they get tested regularly. So I discovered this during the monkeypox outbreak. We'd go to these massage parlors with for this gender, and they don't get tested because it says in the law it's the women that get tested. So the women are luckier; they get HIV testing regularly if they're in that trade, if they're in that profession.
Sek, baka sabihin naman nila you're genderizing.
Well, the key is it's voluntary. In fact, what I want to happen now is that we now include HIV testing for pregnant women. So what I want is what we call opt-out testing. So you go apply for a job. HIV will one of those tests that's going to be there. Syphilis is one of those tests actually. It's called the VDRL. So when you get employment, it's actually part of the screen. So we'd like to put it there. We'd call it opt-out testing. It's up to you. If you don't want to be tested, if you know you're positive anymore, I'm gonna magpa-test. It's your right of privacy to actually do that. So, pwede kang mag-opt-out. But it would be good to have that when you enter college, as a scholarship. May check-up tayo doon, X-ray, blood test, urine test. Isama natin yung HIV doon.
Alright.
So, I will get to test more people. We will catch them because I'm thinking we're still not catching all HIV positive.
Right.
We're still only catching 66%. So there's a 30% that are lost, na hindi nagpapatest. Why do we know this? Because when we test them, their CD4 counts are low. What does that mean? They've had the HIV for a long
longest
time,
time.
and they haven't tested. So we'd like to catch them when their CD4 counts are high, so that the treatment will be effective. Malaking problem tong HIV.
Right, I
and
understand.
I do hope
Mahaba-habang usapan.
I can come back and talk about HIV.
I know you're very busy, but I hope for a part 2.
Yes.
Let's talk about other things, of course. But thank you so much for your time, and hope to see you around. We'll be watching all of your programs.
Thank you, Angela.
Thank you.
Yeah, stay healthy, everybody.